Kindly make sure all of you are muted as we welcome Dr. Anil DCruz on behalf of the Surgical Society of Bangalore to deliver the prestigious B.N. Balakrishna Rao Memorial Oration on the occasion of Surgeons' Day celebration. It is said that it takes 5 years to learn to operate and 20 years to know when not to. Most of it is due to experience and partly due to research. So the chosen topic of the oration is research and clinical practice. Are they sides of the same coin? Dr. Anil DCruz, the stage is all yours.
Thank you very much, Manish. Thank you for the kind introduction. I do remember you from the days in Bangalore. Thank you very much. I must also thank the leadership of the Bangalore Surgical Society for the opportunity to be here today and deliver this very prestigious Professor B.N. Balakrishna Rao oration. It's special for me because Bangalore is a city where I started my medical career. I probably spent the best years of my life. It's special to me because the two senior surgeons felicitated today both come from an institution where I trained, both in and around the time when I was there. It's special to me, as Dr. Rajan said, I was in the first batch of surgery when he came back as a young, very enthusiastic, trained surgeon and would quiz us a lot in surgery. Probably that kindled my interest in surgery. Of course, it's special because Dr. Abhay Dalvi was across the street from me for many, many years, and we interacted on many platforms, teaching sessions in KEM. And also someone who's not been mentioned, Dr. Uday Bihal. I started my career with Sirish Mansali. Uday was a resident surgeon, and I fondly remember him for the first appendix that he gave me. So today is a very special day. It is also special because we are honoring a great legend, Professor B.N. Balakrishna Rao. His brief curriculum vitae is put up here. He was professor and head Department of Surgery at Mysore Medical College. He was then in Gwalior in leadership position. He became the dean at the GR Medical College for a long time, and then professor and head at the famous All India Institute of Medical Sciences, awarded the Padma Shri, and also he was honorary surgeon to the President of India. So it's truly an honor to be giving the oration in the memory of such a great legend.
So please make your screen full screen, please.
Oh, sorry. As said in the introduction, I moved out from Tata's. I now wear two hats. I'm president of the UICC. It's a pleasure to chair board meetings where you give direction to cancer control. We have members in 172 countries, and we do it through the three main pillars of advocacy, convening, and capacity building. I continue to be a head and neck surgeon where I operate, I research, and I teach. When given a choice on what topic to choose, I could have talked about oral surgery and thyroid surgery, but I thought, let me take something offbeat to inspire youngsters that are listening to me, and also, as said today, to probably give guidance to the seniors that you could motivate a lot of youngsters to do research, which is impactful, will change how our patients do, the lives of our patients, giving better results, and more importantly, give our country and our specialty a stamp on the global map. Now, you all will wonder, what is this busy slide? This is the Hippocrates oath that we all take as doctors. I've highlighted just one line in red, and I want you to focus on that. I will follow that system of regimen which, according to my ability and judgment, I consider for the benefit of my patient. So we have to do well for our patients. Now I'm bringing you to a common problem that I see in head and neck, and you all will have similar common problems in your own practice. Management of the clinically node negative neck in early oral cancers. So here is an early oral cancer that has been excised with clear margins. There's debate over what to do with the neck. There are two schools of thought. One says wait and watch. If the patient gets a neck node, you do a therapeutic neck dissection because you're avoiding surgery in 2/3 of patients, avoiding morbidity, costs, and other things. The other school of thought says do an elective neck dissection. It gives you better control and survival. Now, I've just put a certain number of studies over 5 decades. The first randomized trial trying to answer this in 1980. No real conclusion. And then I bring you to the bottom of the slide. In the year 2015 and in around just a couple of years back, in the two boxes that I have highlighted, you can see half the people are doing the wait and watch approach and the other half are doing the elective neck dissection. So now let's get back to the Hippocrates oath. Who's doing well for their patient? I'm sure, in the words of Professor Richard Simmons, common clinical problems are approached in diametrically opposite ways by surgeons with similar training backgrounds, having read the literature, but interpreting the available information differently based on unique personal experience, vision, or preferences. I tried to address this problem of neck very early in my career and probably did the largest retrospective study and again found no difference in outcomes when looking at over 350 patients. And I thought there is a need to do a randomized clinical trial because we believed that patients who didn't have an elective neck dissection were failing, were dying, but we did not have level 1 evidence to change treatment. So sometime in the early 2004 to be precise, we designed a very simple trial. Looked at patients with T1, T2 node negative cancers, randomized them to two simple arms. One arm had an elective neck dissection and one arm were wait and watch, and we did a therapeutic neck dissection when these patients relapsed. 500 patients were analyzed, and here is the breakup of the two arms. Look what happened. When you did an elective neck dissection, there were 50 deaths after in that group of patients. When you did a wait and watch, there were 79 events or deaths, translating into a 12.5% in overall survival. 80% if you did an elective neck, 67.5 when you did a therapeutic neck, with a highly significant p-lab value. There was a 12.5 difference in survival. So we demonstrated level 1 evidence that lives were saved. Elective neck dissection should be the standard of care for early node negative oral cancers. 1 death is prevented for every 8 patients treated with END. This is on the 12.5% difference in overall survival. I bring you back to this slide that I put on again, and this is just a certain number of studies that fit on the slides. There were so many other patients who were either treated with elective net, wait and watch. There were many other publications and there were many others that were not published. But if I just count the patients on this slide, there are 1,000 patients in the wait and watch arm, and it amounts to 125 deaths. So go back to our Hippocrates oath. We waited and watched our patients in the belief that it was best for our patients. We didn't do the research. We sacrificed 1 out of every 8 patients that we treated without an elective neck dissection. I grew up at St. John's, and then subsequently I did a short stint in an ICU to learn critical management. Any patient who walked in with a head injury, we used to say, give steroids, give steroids. Look at the MRC crash trial. Started, planned at 20,000 patients. They stopped the trial at 10,000 patients, 239 hospitals globally, 49 countries, all patients with a Glasgow Coma scale of less than 14, randomized to 2 arms, steroids and placebo. Look at the relative risk and the excess in mortality when you gave steroids to patients who had head injury. It was a norm when I trained. Translate this into numbers to treat. 2 million Americans have head injuries annually, 52,000 deaths. 64% of trauma centers use steroids up to the mid 90s. 10,000 of these 2 million would probably be killed in that period using steroids. And look at it worldwide, 3 million people have head injuries. And I put up the World Trade Center and the crash with the aircrafts. There were 3,000 deaths in that case. Just to draw, I know they're not comparisons, but just to place that the innocuous use of steroids could have resulted in so many deaths had research not been done and changed the way we practice. Now we know it's important to do research, so why aren't we doing it? Here is a study that I did when I was at the Tata Memorial Hospital. 74.5% of doctors surveyed in an oncology conference, they believed research would change practice. 71% had experience doing simple research, but they were not practice changing. They were pharma studies. They cited various reasons: inadequate training, lack of time, lack of encouragement. Surprisingly, and focus on the last bullet, 50% of respondents without experience in clinical trials worked in academic institution and perceived lack of time to do these studies. Is it really so difficult? Do we have to do some earth-shattering studies? I showed you that it is not so difficult to do these studies. So because of these constraints, people don't do studies. They say it's not for me. It's only in America and Europe. It's for guys in the academic institutions in all India, PGI, Tatas. It's time consuming, it's costly. My study that I did, and I'm not showing this study off, but just to inspire youngsters, was the first surgical to come as an ASCO plenary. It was the first global study on head and neck surgery to come in the prestigious New England. It's now quoted across all guidelines, and I've just put the ASCO. It's part of ESMO, which is the European guidelines, the Spanish guidelines, the Italian guidelines. So it's part of all guidelines. It was a simple study. I just took 2 groups of patients. We were treating them and randomized them into 2 groups and analyzed data at the end of about 10 years when I had a critical number. You don't have to be too fancy in your thought. It should be simple, but the topic should be hot. It should be impactful. Look at another prestigious study from the New England Journal of Medicine. Topical 0.5 ivermectin for treatment of head lice. See the authors, none from our country. This is a foreign publication. Head lice is such a big common problem in our country. I'm sure someone from our country could have done this simple study and had a publication in the New England Journal of Medicine. 2 groups. Give one ivermectin, don't give the other, analyze your data and you're fine. Is it costly? Here's what I spent for my trial, 20 lakh rupees, 30,000 US dollars. People would laugh. It was standard of care to do either wait and watch or to do the elective. I just needed one dedicated trial coordinator and one fellow to monitor all my data. So it's not, doesn't have to be millions of dollars to do a study. You can do it anywhere. The first real randomized trial was James Lind on board the ship. For those of you all who don't know James Lind or don't recollect James Lind, he was the man who told us that vitamin C prevents scurvy. What did James Lind do? On board the ship, he took 12 sailors. He gave 2 sailors a quart of cider. He gave 2 vinegar. He gave 2 seawater, so on and so forth. And you'll all know that the persons who got the 2 oranges and a lemon lived and did not die of scurvy. And that's how we discovered scurvy. Simple study, randomized, done on board the ship. So you can do it everywhere. You don't have to be in a big academic institution. Look at the 2015 Nobel Prize to Yo-Yo, a Chinese, not a medical doctor. She was like a chemist who worked on artemisinin and discovered that it could treat malaria. It started during the Vietnam War when her president directed her to read this little study on traditional Chinese medicine, and that's how we got artemisinin, and she got the Nobel Prize. We have so many novel traditional medicines in our country. You could always try them in some of your patients, but it needs a lot of good background research and putting your mind to doing this study. Research helps, and here is an NHS survey on colorectal cancer. They looked at over 200,000 patients with colorectal cancer. Institutions that did research had much better outcomes. Lower post-operative mortality, improved survival. Look at the statistical p-value. 2 zeros and a 1, so it's highly, highly significant. It was much greater in centers with longer participation in clinical trials. And even if your patient is not on a trial, it has what is known as a bystander effect. Patients who are not on the trial also benefit because there's improved and rationalized decision making. There's institution does evidence-based practice, and that institution, those researchers explore more regimes, more instrumentation. And that's a point that was today said in the felicitation program of both our senior surgeons, that they both explored, they brought in new regimes, they were curious to bring in more things. That should serve as an inspiration for our youngsters to go on and do research. It's important, if you don't do research, to practice evidence-based research that others do. And here is a famous quote that I use of David Sackett. It's an old quote: good doctors use both individual clinical expertise and the best available external evidence, and neither alone is enough. So if you practice, you're a good clinician, you must have good external evidence. It's much better if the evidence is developed by you. If you don't want to do research, at least audit your work. Audit has proven to be very beneficial. Clinical departments benefit from a definite audit plan. It improves outcomes, and audits can be in your hospital, they could be patient-based, or they could even be national. And we've got leadership of the ASI here, and maybe one of the thrusts of the ASI should be to have national audits for laparoscopic, for hernia, for piles, for common procedures. You can't operate in the UK if you don't put up your thyroid complication rates. Patients go and look at who has more parathyroid damage, who has more recurrent laryngeal, and then opt for patients. So simple audits, if you don't want to put it in public domain, it's in public domain there. At least we tend to improve ourselves if we know our real complication rates. And just capturing data, I've put up this photograph of Dr. Bavaskar. He practices in Ratnagiri, a place which has a lot of red scorpions. Just documenting his data, 2 prestigious publications in the Lancet and the British Medical Journal. Very inspiring man. We both got felicitated together some time back at an award ceremony. I spent an evening with him, and I've put this lovely photograph of him in his office, telling you that you could do this kind of audit in a small place, and you can hit some of the biggest journals that we all crave for from big academic institutions. You need to have the right attitude. Things are improving. And I've looked at publications from 1987 when I started my career in surgery, stroke, head and neck oncology, and I've traced it to the current year. And you can see this big peak in the number of publications coming from our country in head and neck cancers. Head and neck is our cancer, and it is for us to teach the rest of the world. And I'm so glad that we are having more and more publications, and they're coming from institutions across the country. I've just asked my fellow Dr. Satakshi to grab some of the publications from just Bangalore and Karnataka. And the majority of these on the screen in the recent past are from Bangalore and Karnataka. So that's good news that we have people doing these kind of studies all over the country in impactful journals, in journals that are specialized in this particular subject. And I've only focused on head and neck. I'm sure it's happening in other disciplines as well. So youngsters and seniors, youngsters, grab this opportunity. It's a golden opportunity. Seniors, motivate your youngsters. If you do research, apart from improving outcomes of your patient, there are personal gains. You get to be known, you're respected in your field. The department and institutional gains. Your department and your institution gets world famous. They're national gains. Importantly, they're gains for patient and mankind. You're saving more lives. You're getting better outcomes, less morbidity. And there's some intangible gains. And what are intangible gains? I did the neck dissection trial. And now when you put DCruz and neck, look at my photograph popping up in between the neckline of Ileana DCruz, who's a very, very famous artist. So these are some kind of intangible gains. So if there's someone Googling DCruz neckline, here comes my photo. So some intangible gains of doing research apart from impacting on outcomes and decreasing morbidity. So my topic was research and clinical practice. Are they two sides of the same coin? I think I've kind of demonstrated to you that it's important. You save lives. It can be done by anybody, improves outcomes. And even if you don't do research, simple audit can impact on your outcomes. But I won't say they're two sides of the same coin. There may be two sides, but the print is the same. Research drives better clinical practice. And it's something that all of us must imbibe into our departments, into our practice, even if we are out of academic institutions. You must remember that 3/4 of all big trials in cardiac practice have come out of non-academic private institutions. And that could just be a stimulus for many of us who are now in the private sector, have great infrastructure, great patient load, have good follow-up of our patients, to not leave it just to academic institutions. So every mountain is within reach. We just have to keep climbing. Thank you once again to the leadership for this opportunity to share my thoughts, motivate youngsters for research. How I wish it was not virtual and I'd been in my favorite garden city of Bangalore. But Venkat, the president, has promised me that he'll bring me back someday into Bangalore in the near future.